of an N95. They are different sizes, so you do require to have a fit testing. You needed to call into a fitting testing facility. That is, book an appointment, is one person at a time, so we'll take it a little bit time to get your whole practice in. So it's not gonna be a group fitting or like CPR we're used to doing in a group setting. And you do have to provide your sizes. So that is the struggle right now that we're having. And facial hair usually is ideally to be removed for the sealed aspect of it. So if you get a hold of an N95, be able to be fitted, will be valid for up to 2 years. So it is one step that you do, and the validation is for 2 years into the sizing. So you are gonna have to renew it, and it has 2 years passed by. So CDC has gave us guidelines to how to extend the lifetime of your N95. And there are a few things then we can do it. It is at the end of the day, you will place it into a vented type of container, so a Tupperware or something that you can have and making sure that it's vented. Then you also would have to be using that N95 with a level 2 or 3 mask on top and with your face shield. This way we prevent it from getting direct aerosols contact. Please know that you cannot wear makeup with, because that creates already cross-contamination and a surface that will create a porous and area that can be attached to aerosols and other cross-contaminations. You also want to make sure that you evaluate the quality of your mask at the end of every day. So if it is being soiled, it is in contact with aerosols, your elastics and your fitting has been compromised, that is a time to redo it. So those are things that are being recommended by the CDC, and it can help extend the life of your N95.
So you're saying put it in a vented container at the end of the day. You're covering it with another mask, right?
Yes.
Put it in a vented container at the end of the day, because we don't in dentistry have the sterilizers that are able to sterilize those. Those are for hospitals, right?
Yes, unfortunately right now there are some Canadian companies who have been developing sterilization units for our masks. So it's not placed in your autoclave or your stadium, you cannot do that. So it is a specific UV light with a spray system that helps with the sterilizations. They are available for dentistry. So if you want to look at and invest into that equipment, of course, you can. It is available, but it's not a simple sterilization process like we do with our instruments.
Right. So if each provider had 4 or 5 N95s, they could find a rotation system with covering it with another mask that are available. That would, how long could they use that?
Until you have it to every day verify the quality, and if it has not been soiled or damaged through the day, right?
Or so the strap breaks.
Yeah, so you have it to always making sure you evaluate after every appointment, because at the moment any PPE, not just your N95, any PPE becomes soiled during your procedure, it has to be, right now is compromised, so you're not 100% safe, so it needs to be replaced.
Okay.
Well, with regard to the N95, we're talking about AGPs. Has there been clarity from the different provinces with regard to the potential for investing in closing off rooms?
I knew we'd get to this. So here's the challenge, and anyone can interject here. Saskatchewan made a statement that all rooms have to be closed and sealed, floor to ceiling. And they have to, after an aerosol generating procedure, they have to sit for 120 minutes. So there has been a lot of reaction in response to that. There's petitions going around with dentists asking for evidence based on that. And I think the challenge is so phase one, because Walter and Dr. Rob and I were talking about this. For phase one, those other provinces haven't said you have to close your room. But if we look at the common sense of aerosols do move out of an open room. So are people closing their rooms? They're working on it. I think the question is closed rooms going to come from those other provinces in phase 2 and phase 3 when we get into more elective services? no one will answer us. Okay, so do I think you should do a massive renovation? Not yet.
Oh, well.
A lot of you have open rooms, but I mean, here's the thing: protecting yourself is the PPE. The PPE is protecting you. And after all of our new intake forms and our screening and our patient flow, and next week we're going to get into the every step of the patient flow, because every day there's new information, and until all the colleges have come out, so that's what next Tuesday's town hall will be about. But I think answering your question is, there are some people closing their rooms just because they want to get ahead of it, whether they were told to or not. But I think right now in phase one, I think that you're adding some aerosol generating procedures, because if you look at the definition of what's allowed to be done in the urgent procedures, there's going to be 1 or 2 rooms. And what's really important here is that you're only coming back with a skeleton team of a dentist, a CDA, and someone possibly in the admin to be able to do the intake, the screening, the taking of the temperature. So the good news about bringing in a skeleton team of that size is not only can you get your operatory set up, you can get your doning and your doffing stations, and we'll talk about that, but also you can practice before you bring back the rest of the providers, because there's a lot of new procedures, new systems, and new behaviors needed, whether you have a closed room or an open room. So that's as far as we know right now. I'm telling you, it perplexed me that after Saskatchewan, the other colleges didn't even really speak to it, except if you're doing aerosols, wear your PPE. So I think that's still to be determined.
So there's many questions that are being stated here, and we need to recognize the fact that we're not going to get through all of them, and that there will be another town hall meeting next week. That's
every Tuesday until we're fully up and running. There'll be a town hall.
Every Tuesday, 1 o'clock until you're fully operational. There's a question here with regard to HEPA, ultraviolet ozone. What should the dentist be considering?
Walter, do you want to speak to that?
Yeah, absolutely. So I think what we're dealing with right now in dentistry is this whole concept of an aerosol. So as the aerosol is in the room, we, practicing for 25 years, we in dentistry have been dealing with aerosols our entire lives. And there's much research that identifies that an aerosol in the room will settle down within 10 to 30 minutes. So there's science behind that. What they're talking about right now is this concept of a ACH, like an air changes per hour. So how do you change air more often so that settle time can become less? Some colleges are talking 2 hours to 3 hours of not using a certain environment based on the aerosol that's being created. So in a closed environment, if you do nothing, that aerosol will settle down. They're suggesting 2 to 3 hours. Research is suggesting 10 to 30 minutes. To increase that limit of time, to make it faster, to settle things down faster, you can introduce HEPA filters or air exchange units inside a room that will move the air, circulate the air, change the air, call it from bad air to good air, and do that within 5 to 20 times within an hour period of time. So the idea behind that is that you're bringing the air quality and the aerosols into a good quality air often, so that you're trying to reduce that 2 hours down to a certain number. These companies that are making the HEPA filters, they have calculations for the cubic square feet in a room, how fast the machines are circulating the air, what type of fans, what type of filters do they have, carbon filters, HEPA filters, UVC lights inside the filters. If they have those things, there's some science that says when the air comes in and the air goes out, it's clean. It's by 90, 99, 97, 99%. There's research that is showing this. And in a room of that size, they can dictate to you how fast that settling period is. And many of these companies are showing results of 6 minutes to about 15 minutes, 16 minutes, in terms of what is really a room that can have an aerosol that's settled down or the air circulated 100%. The challenge is that the equipment that you're going to get to do the HEPA for you, you also will need at some point some type of professional to do a calculation of the room, the movement of the air, to give you like a certificate that this type of room is able to support the next client at a certain period of time.
Well, can we call on Rob? Because Rob, Rob was telling us about Jade. Rob,
Yeah, I got a letter. I got a letter yesterday or an email a couple of days ago from Jade, and they told me that, and they referred to Saskatchewan, saying the document Saskatchewan Health Authority indicating a dental office must wait 2 hours in between patients for a single room. The air exchange when you use a Jade.
can you explain what a Jade is in case people don't know?
A Jade is a multi-speed air cleaner with a bunch of, I think it's got like 6 or 7 different filters. And what they're saying is they have 3 speeds. The one speed they have, they cleans the air. They talk about cubic feet per minute. And if you take the average dental office of being 10 by 10 and 9 feet high, you've got 900 cubic feet in each room if it's closed off. They're saying that if you use a Jade, something, or a Cascade, there's 2 different brands that they talk about. The Cascade is a 6-foot monster. A Jade is a 3-foot high, 12-inch diameter machine that you can keep inside the operatory. They're saying if you use a Jade at the high speed, which is a turbo setting, it cleans 383 cubic feet per minute. And if the room is 900 cubic feet per minute, you can do the math. It's going to take, and it cleans the air on a turbo every 2.5 minutes. 2.5 minutes, they turn the air over. So, and they're saying that you can cut down the time to 14 minutes. Now, even if you cut down the time to 14 minutes, the cleaning of the room is going to take at least 15 minutes. Forget the aerosol right now. The actual scrubbing and waiting and going back, and I think, Luce, you can talk about that. The actual physical cleaning is going to take longer than what the Jade can provide. So if the Jade provides you 20 minutes of air time or 15, you're not going to clean the room in 15 minutes. It's very difficult unless you get a team. And I think that's unrealistic. So, you know, moving forward was what we're going to do in phase 1 or whatever phase we're going to open is we're going to run 2 operatories. So we'll run the first operatory. We'll put our Jade in there. We will spend as long as we have to for whatever we're doing. We'll close the room down afterwards, and it will take a half hour to clean the room. In the meantime, we'll be opening another room, and we'll have 2 operatories for hygiene when it opens. We'll have 2 operatories for a doctor. And, you know, we're lucky. We've got 12 operatories here. So we're able to run when we're phase 1, phase 2, when we're doing an opening, we possibly could run 6 providers working 2 rooms each, and that will take care of all of the downtime. If we have to wait an hour, we'll wait an hour. At least we're running 2 different rooms. Right. So that's one way of doing it. And I'm not, you know, and we closed all the operatories, and I'm not closing the operatories. I didn't buy Jades. You know, I bought Jades for all the rooms. I'm closing all the operatories. That's optics. I don't know, and there's no rules telling me that I have to do it, but I'm not a rule, I'm a rule breaker. I do things, I don't mean I'm a rule breaker, I just do things before you have to do them, and it's what it is. I mean, I had a patient call me yesterday, and the first question she asked me, what are you doing to protect me? Oh, okay. I mean, that's what they're going to say. And they know from, you're right, they know 95s, they know KN95s, but they also know asymptomatic. And I believe asymptomatic is the word that patients are going to want to say. Asymptomatic, and I want to be in and out. Get me in, get me out. I don't want to see anybody. So, and I need to be asymptomatic. What are you going to do to protect me? Yeah. So I went ahead and bought Jades for every operatory. Right, I now purchased, and I just ordered and measured for a glass structure to be set up in my waiting room. So there will be a station when a patient walks in, completely isolated from the rest of the clinical operatories. They will walk in, they will get, hopefully we'll do with online forms. We'll send forms out before the patient will come in. We'll get them cleaned up. We'll get them sanitized, a new pair of gloves, whatever it is. And then they'll cross over into the section that is going to be sterile. And that's a job. And I did it because I wanted to do it in our office. That's what we do. Now,
well, and you also have the room, okay? So
I also have the room to do it. That's correct.
Yeah. So on this patient check-in, as well as we've been calling it, the virtual parking lot.
Yeah.
Right.
I'm in the mall. They can virtually park outside the mall.
Yeah. Or yes, in your case, because you've got the people outside the mall. But I think having a screening mechanism, we'll talk about, again, talking about the days of having a patient walk up to a front desk, at least in this phase, walk up to a front desk with no protection and have a seat in the reception room. So those of you who haven't read all of our information on the COVID survival guide, please go there, because there's a lot more detail of we're how trainers and systems. There's a lot more steps of how to prepare your facility. But also, I think on this aerosol topic is what you're saying is patient confidence is going to be a big deal. They all know
what I want to do, Lisa, is I want to make sure that the patient notices something different. They cannot expect, and you know, we were, what do you call, state of the art? We did everything we were supposed to do, and clearly it's not going to be enough moving forward. And the patients, in my opinion, need to see something, or at least in our office, need to see something that's going to say, wow, thank you. Thank you for taking care of us, because ultimately that's what they want. You know, taking care of them and take care of our staff. So I went and we decided we weren't going to take throwaway gowns, for example. I am not polluting the environment with, if you think about it, how many patients you see. Let's say your office is, you know, we've got a lot of operatories. If we see 500 patients in hygiene a month, or whatever that number is, that's 500 gowns. And that's a lot of gowns you're throwing out. That waste basket is going to be pretty big. So I went ahead and I got a hold of a company that purchased gowns for us. So I bought 400 gowns. And those gowns will mean that I will always have 200 in the room. They'll turn them over as quickly as they can. They'll wash them. They'll charge us a fee for washing. And I bought them from the company. I bought them from Faster Linen, if that's the company I used. It was the only company I could find that will provide and purchase the uniforms. We paid for the uniforms. We get them serviced by them. They charge us a fee per item. They bring them back. They're clean. They're sterile. They're perfect. And then at the end of it, if we choose to get a washing machine here, we can stop the service anytime we want. So, and I don't have to throw anything out.
Right.
I don't want to do any more throwing out. So what I did was I took the money the government gave us. They gave us $40,000. I said, I'm going to spend the $40,000 and invest it back into the office and see what happens. It didn't cost me a dime. So in a year, I can pay back the 40. I did it. I took the 10 that we get for free. So I used that money.
Great, thanks.
That's an optics thing. And I'm not told what to do. I don't know what the rules are, but I did it because that's what I want to do.
Yeah.
And that was the optics thing.
Right.
100% optics. That's it.
And your patient is more educated now, right? Like everyone knows what a PPE means now. Everyone knows what aerosols and that. So we needed to be proactive.
I think so.
Start from your screening on your patients to, they will appreciate that, and you really help them understand what is expected, how soon they come in the office. It's not going to be the same anymore.
Right.
The last company I did not want to put up the things you see at Loblaws, those plastic things that they lean in, they're going to fall. I've got ceiling to desk glass. I've got inserts so you can put your hand in and you can do a visa exchange on the machine. I actually put one of those speakers in you see at the TTC when you walk in so you can talk through a filter. So, you know, that's what we're going to do. And I think it's going to look great. And I think that patients, when they walk in, are going to say, wow. And if you can wow the patients in this environment, I think, and that's why we did it.
Okay, a couple questions for Lisa. So one of the questions we have is, where do we get this COVID-19 survival guide?
TGNApracticemanagement.com. It's the front page of our website. Gavin's pinned it right to the front.
Right. Second question on that. Will we have access to the slides that are being presented outside of the webinar form?
Sure. Yeah, and actually everyone on this town hall is going to get, as your follow through and you're registering for next week, is a master checklist that the transitions team and I have written over the last 2 weeks to get you to return to this stage of absolutely every step that's needed. I think the big question was always about the equipment and the PPE, but there's going to be a completely different way we communicate. Any resource we mention is on our COVID survival page. I know Chris, with some encouragement this week, wrote a step-by-step on how you call employees back off layoff the right way. Okay, you're not going to call everyone back. I know that there's dentists bringing back the employees using the 75% subsidy and not paying the other 25% because they can prove they have no cash flow. Someone was asking about the CEWS. So I think it's a staged startup, and there's going to be people at home still waiting for you to call them to tell them to come in. I have people ask me every day when Hygiene's coming back. I don't know. And we'll cross that bridge. I don't have a crystal ball. We'll cross that bridge when we get to it, but we need to be perfected before they arrive. Mm-hmm. And perfected means have equipment for them, have our processes in place, and then that'll take any dissension between the colleges competing on what's the safety of a hygienist versus what a dentist provides, those kinds of things.
Lisa, just an up-to-date thing. I ordered, I this morning, I tried to find out. It was $8 for a disposable gown that they were charging me. A box of 10 were $80.
Yeah.
N95 mask is $15 an N95 mask right now. I ordered a box. I mean, but the bottom line is, I'm also hearing from the Kois chat line in the States that the N95 masks are only 2 sizes. Correct me if I'm wrong. There are some faces it won't fit. Like if it's long and narrow, it doesn't fit. It won't seal it.
Lucy, am I accurate that if everyone gets a large, the fitting will make it fit, or is that not true?
They have a standard, and then they have what is usually a medium and a large, right? Like it is, most people will fit it into it, like we has our society shapes and sizes, but we are requirement to, most of the ones will be landed into that one, absolutely. But it is recommended if you can to your PT staff, then potentially you're gonna have, we are in a female driven industry, that you potentially will need some smalls.
Right. So if it's a matter of, I don't have an N95, but I want to be a dentist and service my patients, you're saying that a KN95 with a shield is just as good.
So they have a multiple areas that you can look into. The N95 is the most common that we hear a lot about because it is in our continent standards, but you have also European standards. So you have FPPE and a PPE2, who are the European standards. They're also very relevant and comparable to what we are having. The KN95 is the second most common, of course. And then we can still have some other, I can send it out to the link for you to pass to everyone what are the comparisons.
Okay. So from the COVID survival guide resource to how to deal with the human resources, to what team you select to bring back, and then making sure, you'll see in our COVID survival guide, making sure you do some in-service training before you start. And this is the time of what's called doning and doffing. And you'll see it on the survival guide. Doning is putting on a PPE in a clean area, and it has to be separate from a dirty area called doffing. So you'll see a list of all the things you need to buy, from sanitizer. We're going to need all kinds of hydrogen peroxide. I think there was a study that someone sent me this morning saying that there's a type of Listerine that has the same, a make of Listerine that has the same characteristic. Okay. Keep in mind, pre-procedural peroxide rinses have been in IPAC for a long time, right, Lucy?
Yes. Yeah. So it is a Listerine whitening. It's always a best practice, right? So the pre-procedures rinse always be considered a best practice. Right. So just to keep that in mind, that is a shortage out there right now, but a hydroperoxide has been proven to affect the COVID, including into cleaning products. So there are some wipes out there who also have the peroxide, who will help with your environment cleaning, which has important as your PPE. Yeah.
So Rob, could you please state once again where you bought your gowns and who's going to be laundering them?
I hired a company called Faster Linen.
Faster Linen.
Faster Linen. Yeah, exactly how it sounds. The guy's name is Ben. He runs the company. They purchased gowns for us. Yeah. They charged us $30 a gown, and those gowns are ours when we stop the service, and they're charging us a fee per washing, and they'll make sure that we're gowned. So
Rob, the fees, because I guess the other question is, some practices do have washers and dryers. So
and you can buy the things. I mean, I couldn't find anyone at that level. I thought a $30 fee for the yellow ones, and they're great with the cuffs, the whole thing. I thought that was the best fee we could find because they're not around. They're hard to find. So I wanted to secure them. And then the problem is that, yes, we can't put a washer and dryer in here because we're in a mall. We have to vent it, the
Yeah.
dryer 200 feet. So it's insane. And I don't want them to take home the gowns themselves to home.
Right, and keep in mind, it does state you can wear a lab coat. You just have to change the lab coat every patient, which is why you ordered so many, right, Rob?
Well, it's not the lab coats I found were very expensive.
Yes.
You can't find a lab coat under $50 that you're going to want to wear. This one company that makes great lab coats, one that charged me $100 a lab coat. And if you need 10 or 12 or 20, because you're not going to, if you see 5 patients a day, you need 10.
Yeah.
And they're not light. The lab coats are heavier than these gowns, and it's hot. So
I'm sure Ben will be happy about your plugs. So there are different provinces that have different companies. My clients in BC are looking into them. You're gonna see anywhere from $60 to $100 a week for someone else to wash them for you.
yeah, they're all going to charge you, who knows, $1, $1.50. It depends on where you are and the volume you have. I mean, there's nothing you can do. But if you want your staff to take them home, then go ahead.
I saw a question here. If you have your own washer and dryer, it's basic, wash them in hot water and dry them, right, Lucy?
Yes.
Yeah, there's nothing special that needs to be done, no special detergent.
No.
Okay, other questions, Rick?
So this is going to cost the dentist a lot more money. We anticipate, how do we anticipate recovering those costs? And will there be a change in the Provincial Dental Association fee schedules, do you expect?
Well, I wish I knew that. I think that's why we've all got to gather together and lobby for what we need to be successful. I don't know. I can't speak for that. I mean, Walter, do you have any thoughts on that?
Yeah. So the cost per visit is going to increase, no doubt. The number can change anywhere from $10 to $25 of actual cost, depending on the type per visit, per patient, depending on the type of procedure you're doing. So when you have volumes of that type, it becomes a very strong number. And in many places, a lot of dentists are talking about passing that type of fee on to the client. So if you're passing that type of fee on to the client, it raises a lot of other questions in that, are you starting to do dentistry and are you now doing one filling per appointment, or are you starting to do quadrant work? Are you starting to do more work in a shorter period of time or more work in one appointment, so that the cost of these things are starting to become less per patient? So our solution right now in the dental practice is that we have a fee guide, which we try to follow, but this is an additional fee. We as a practice will pass that on to our clients. We will be very transparent with what that fee is, and we will identify that fee, and we will show them strategies on how we can reduce that fee by having more visits, more appointment procedures in one visit versus breaking it up into multiple visits.
Yeah, and I think there also too, keep in mind, gang, that there is an antibodies test being tested right now at Health Canada. I believe dentistry could be back to fully functioning. It'll never be like it was. We can't, I mean, that's the past. We just have to celebrate. But they're coming out with an antibodies test that's going to be able to be delivered in dentistry. And if that costs $20, $25 and a patient can get that at the dental office, that probably would be an easier transition into asking them to pay for, whether there's a code or not. I mean, for our full return, we're going to have to maximize dental benefits like we never have before. Well, while the Canadian public gets back in their positions, if they even get their job back and keep their benefits. So I think that's the part over the next 8 to 12 months. 8 to 12 months of how we rebuild to what we were in thriving, profitable, well-run dental practices.
Yeah, Lisa, can I add to that?
Yes, you can.
So in regard to where we are as a society, the tests that we've had so far are only tests to identify if a patient or a person has been infected. So it's basically a yes or a no. What we do not know is that the population that's out there, have they been exposed and have they developed antibodies? And that's a real significant question, because if they've developed antibodies, short-term or long-term antibody, IgG or an IgM, those two things will help protect the individual from getting reinfected. Now, there's a lot of research that says, will you get reinfected and so on. The challenge is that if you've already had an antibody built into your system, into your healthcare, then what happens is you're stronger for future infections. If we can see that with every patient that walks through the business, that we can provide a service, a medical service at a level where we can identify for them, they have immunity that's built in, their confidence in dentistry will start to change. And right now with these antibody testing that are coming, we have applications within Health Canada, and these applications are going to be acted upon real soon, but they're going to disperse these to healthcare frontline workers first. We as dentists, 40,000 across the country, we're perfect individuals to be providing these type of tests en masse for individuals. So pay attention to that. That would be a very strong service you would do for your patients, for your team members. And when you're doing that, the cost of these things may be $25. You may be able to pay for the cost of $25 and charge for your time for doing that. But the ability of bringing clients and bringing an exposure to dentistry at this level would be quite significant.
Great. Any more questions, Rick?
Oh boy, there's lots. With regard to, bear with me one second. Do you know if diluting hydrogen peroxide from 35% to 1% is safe?
Lucy, any idea on that? I have no clue.
Okay, it becomes a little bit absolutely challenging. We have to making sure then it is the proper ratio when you are measuring. And so ideally, we recommend you to buy already the microbial rinses pre-set. So you have a Colgate products. You have also the Listerine whitening. That has a 1%. Please keep in mind that the peroxide, it is known to be cancerogenic. So we want to make sure that we handle with care.
You're saying no, they can't do that. That would be.
Yes, you can, but it becomes certain responsibilities and making sure then the person doing understanding the procedure properly, step by step, because it can also not be a healthy way of doing business if you are slightly overexposing your patients into more amounts of peroxide than is required, right?
Right.
Study shows then that are conditions into developing side effects and a longer exposure to it. So we want to make sure if you can buy already pre-made and like in the formula of 1% would be the best.
Okay.
Right, and I would say to that, as a practicing clinician in our practice, it would be very difficult to take 35%, bring it down to 1, but it's much easier to take a 3% solution, bring it down to 1. So it's a 3-to-1 ratio, and we can do that all day long. So my suggestion is if you can't find the 1% in pre-mixed, the 3% is a 3-to-1 ratio. As long as you have the brown bottles to store them, and then you're able to put them into a cup for a patient to do the rinsing prior to the appointments, that would work out very well.
Okay. What gloves do we need to cover the cuffs of our gowns?
I don't know.
Okay.
I mean, they're the ones that we wear, the gloves that we wear, what they're actually suggesting is wearing a pair of gloves and then an over pair. Is correct, Lucy?
So it is more to be able to making sure that your cuff is sealed, right? So gloves in general, it is to be, doesn't need to be sterile gloves. Ideally, we've went away from the latex gloves because of latex allergies. So your nitrile gloves would be just fine. Your procedure gloves just to be fine. So it is more
that your wrist isn't exposed, right?
Exactly.
That you're totally covered. Okay.
Exactly. So if you have a cuffed gown, makes it easier for you just to use it one single glove and guarantee that the more gloves you place, you lose some of your tactile, right, into aspect of it. So I think it is more of making sure you have the proper size gloves, the proper size gowns, and if you look into a cuffed one, would make it a little bit easier. Now, when you're doing your sterilization procedures into your sterile bay, then you require different type of gloves. So it is your utility gloves because of puncturing prevention. So there are two different procedure protocols and sterilization protocols.
Okay.
So with regard to the donning and the doffing.
Yes.
In hospitals, doffing has to be done with a spotter. Will we have to doff this way, as well as seeing a skeleton staff being back at work at first?
Well, here's in the research and all the writing I've done on donning and doffing. So I don't know if I've read anywhere you have to have a spotter, but see what donning is putting on the equipment, where the dentist and the assistant are going to do that either outside the room in a clean area where they keep their PPE. They get all dressed, okay? And on the COVID survival guide, there's posters, there's pictures, there's videos. We sent out one from an anesthesiologist of a client of ours, a wife of a dentist of our clients. I think the key is it's the dentist and the assistant that are donning, because once the PPE is on, you cannot go anywhere else except into that room, into the room you're going to work. Doffing is done with lid foot pedal garbage cans, whether you have a laundry one and a disposable one, however you're doing your gowns. And basically all doffing has to be done in the aerosol contaminated room, except for your mask and I believe your shield. And then, so there really is a spotter with the the dentist and assistant, but I can't see the practicality or the reality of bringing someone else in as a third person to watch and make sure you did it right. And that's why donning and doffing needs serious practice before you see patients. And start with the doctor and the assistant practicing it. And then as you bring more team members on, you can teach them as you come. But as far as having another spotter, I don't see the reality in that, because you're going to bring in, who would you bring back? An administrative person who's going to be watching you. So I think my answer to that would be practically and common sense. We're not doing open heart surgery and brain surgery here, but we are working with aerosols. So
like you can do posters, right? So if the idea is
yes,
how to place in the proper order, then print posters and laminate them.
I just put those on the survival guide from the CDC. I think, Gavin, they're being uploaded today. And please feel free to use those, print them, and have those posted. That's also a thing that patients can see, right? You also, other things patients can see for confidence is having a bathroom cleaning log in your bathroom. Basically, the requirements say every time a patient uses the bathroom, someone needs to clean it. So, I mean, you've got, if there's a cleaning log, it's all going to be ways, how do we answer the patient that we have, we are responding to this? Like, for instance, plexiglass at your front desk is not a mandate. People are choosing to put it up there, temporary solutions up there, because they want to remove it if they think that this is, when a vaccine's created, because they don't want to block their patient relationship. But we don't need to, but they're doing that because patients are used to that, who have been in isolation for 2 months, seeing it in gas stations, variety stores, and that kind of thing.
Yeah, sorry, Lisa, as you're talking a little bit about the donning and doffing, I think we need to clarify, aerosol treatment versus non-aerosol treatment, because that determines really, do you need it or not? So a non-aerosol treatment, you could walk into a room with a level 2 or a level 3 mask, eye protection, gloves, and you're able to do the things that we do in dentistry non-aerosol.
Yeah.
Once we move into aerosol, then the donning and doffing becomes applicable.
Gavin, can you switch back to that other slide, please? Because that's a very good point Walter's making. Here's what's critical. You don't wear PPE for non-aerosol generating procedures. And although they consider an air water syringe an aerosol generating procedure, I think there's lots of debate about that. So I think non-aerosol procedures are exactly what's here. The PPE is for aerosol, handpiece, and ultrasonic procedures for now.
So there's a question here about whether each patient that enters the clinic needs a L1 mask.
Well, I think that's probably come up because Longo's yesterday just pronounced everyone coming to their grocery store needs a disposable mask. Little do they all know those disposable masks don't do anything much. But I think, do they need a mask? We're going to see what we're going to do is they're going to stay in their car until we text them. They text us when they're here. They're going to text us that they've arrived, and then we're going to let them know that that they can come in, and there's going to be a screening done. The intake forms need to be sent out the day before. So this is all things you can be looking at. Your softwares, who can send out the intake forms. They do recommend that the intake forms are signed. Well, if you're getting a patient to sign on screening, you got to give them your pens. So I think there's a lot to, as far as the patient wearing a mask, with everything that we're doing. If we're taking their temperature, so make sure you look for your infrared thermometers. As far as the thermometer, that you can quickly take their temperature and make sure they're not over 38 degrees Celsius. But I think them wearing a mask, I don't know how they're coming into the most, I'm gonna be honest. Any of you been to the hospital? We were cleaner than a hospital in my experience before this. Someone might not like that I say that, but I think the dental office was the most safest place to be with IPAC. So I think them coming in, being screened, and going through that process, I don't know the value. And remember, a lot of the public can't get masks, which is why Longo has to give them out when they want to come grocery shopping, because they can't find them.
So could I just add to that? With the infection control, so your IPAC, we already pre-COVID had a risk assessment for any respiratory diseases, right? So when your patient would come in, you are mandatory, at least like in Ontario for sure, to have a stop sign with a few questions about fever, cough, or short of breathness. So also a mask, so a box of masks for the patient should be there, like available for them.
So you're saying we should give them a mask to take their temperature?
So no, so when you coming in, even pre-COVID, was mandatory for us by public health in Ontario to have it assign a station, would have a stop sign who covers into your respiratory disease. So if you're experiencing any shortness of breathness, fever in the last 24 hours or at the point of contact, hand sanitizers, 70 to 90% alcohol base, a tissue box, and a box of masks. If the patient present themselves with any of those symptoms, they were required to wear a mask into the office. So if you base it into that infection control previous procedures, we still highly recommend to have that, because in public health, when you get audit, that is one of the items it is in their checklist. So has infection control in general, we all should have that.
Okay, so I understand there's going to be tons of hand washing stations everywhere and sanitizers, right? And the different doning and doffing, and we're going to be washing our hands till they're raw. But are you saying that if a patient comes in for the COVID screening, right? Before they enter the dental practice, you're saying they should have a mask? I didn't understand. Yes or no? If for everyone coming, do we need to do it to the masks? I guess. Forget respiratory. You find that out after they get there.
So if you take the concept of IPAC, okay, so I'm gonna speak about in general, and that would include COVID. If we presume every patient is a potential host of a disease, right? So that's why infection controls prevention are built into our offices, because you can be asymptomatic. So exactly the point of right now in COVID, they're saying a lot of more people are walking around with COVID and not being aware of it. So you have the question of too, if you take it in consideration, then your patient is asymptomatic and potentially has COVID and they don't know. So the best practice would be everyone who comes in would stop it at your hand sanitizing station and place it a mask.
What about boots?
Oh.
Yeah.
We can go through over it.
Oh no, we're not talking about boots.
We're not gonna go there, because we can gown them wholly, because if they cough in their arms, then now their arms are infected, right? Their clothing, and we all know goes into surfaces. But I'm just speaking about an aspect of respiratory. Previous protocols for respiratory diseases was to have at your front desk the sign, the mask, and the hand sanitizers, right?
So can I add to that?
Lisa?
Yeah.
All it is and get us sponsored.
Pardon?
Get Adidas to sponsor us, or footwear, or some company to sponsor us.
I already begged Bauer. I already got my shields from Bauer. I'm done. I used all my points.
So let me add to that in terms of, you know, mask or no mask coming in. So number one, we as dentists, we want to pre-screen them the night before. So that's very important. Number two, even if there's no symptoms the night before, and if they come asymptomatic, we're not going to know that regardless. If they come in asymptomatic with a mask on or without a mask on, they're asymptomatic. We're going to do a temperature on them. They're going to be asymptomatic. The most important part right now is the person who's doing the temperature at the front desk, is your reception, is your team member. They need a level 1 mask.
Yeah.
They need eye protection. They need gloves. And those are the individuals that will do the final screening. So if the person's asymptomatic, the screening tool is asymptomatic, they come to your office, they're asymptomatic, they're going to now walk in to a treatment room. So if they have a mask on or they don't have a mask on, they're going to bypass all of these systems to get into your office for treatment. In our emergency cares, we're seeing patients walking in with masks on right now. So they're walking in with masks, they'll sit in the room, they'll sit in the chair, then they'll take their mask off. So I think the majority of these people will come into a dental environment naturally masked up.
Yeah.
But we won't have a policy that when you walk in, everyone gets a mask on in our dental practice. If we screen them properly, we test their temperature, they're going to go into a treatment room.
Yeah, I agree. Questions, Rick?
Yeah, should we be covering the patients with a plastic sheet or a washable sheet because they may have virus on their clothing from the outside the office or from the AGP?
Well, here's the thing. If they have viruses on them, you're geared up in PPE, and my understanding is you're protected.
Right. And so here's the thing, right? So the patient is laying in your chair now, you're doing work on them. The aerosol that you're creating is the aerosol of the patient that's being created on top of themselves. So the gowns that we have right now, not the gowns, sorry, the covers that we put on top of the patient, they're limited size. We have these packs that are metal cassettes that open up. The paper that's in there are quite massive paper. So you can leave them bigger and you can cover the patient more with it. And when you actually look at the aerosol, the spray from the mouth is quite extensive, but that spray in the mouth is reduced by having good four-handed dentistry in there, good high volume suction, good HEPA filters. And if you have these aerosol vac stations where there's like a little hood around to capture the last bit of the aerosol, you're actually creating an environment that saves the air, that saves the movement of the virus and bacteria by 99% between the stuff that you're wearing, the stuff that the patient is wearing, and it protects everyone. So even if you have an open environment, the argument can be made that you have good HEPA filtration, good vac stations around there, good four-handed dentistry with good suctions, you reduce the spray. And as a result of that, I think a lot of these things will become more scientific in their discussion versus fear-based.
Yeah, and keep in mind, a reminder for operatory setup, you'd be amazed. There's not every operatory has high volume. You must get high volume. You must get high volume suction.
Yes, and I think, you know, generally in my experience of seeing this develop, we're involved with PPE, we're involved with antibodies, we're involved with dental practices. So my general experience says air quality is going to be important. Yeah. It's a type of investment where you should have high volume suctions in all of the rooms.
Yes.
I believe that you should, in your buildings, if you have the control of having better HEPA filtration for the whole building, that's wonderful. And the third one is if you have rooms where you can have high volume control of the aerosols with HEPA filters specific to the room, that enhances the experience. And the last one is if you don't have closed rooms, you can make it much more available by bringing in these vac stations that can actually get closer to the patient and reduce those type of aerosols. So all these are publicly facing events, but I will tell you that open practices where you have one patient and another patient side by side within 3 to 6 feet, that type of experience, no matter what you think as a clinician, the patient sitting there with their mouth open looks over at the next patient with their mouth open, they're like, I don't want that. So you're gonna have to come up with solutions to solve that problem.
Yeah.
You know, one of the ways I did it with my staff, you know, you're putting up this glass wall. If you're behind the glass wall, they're not entered the office yet. My staff who I assign at the front, can take a thermometer test through the glass. So there's no contact between my staff unless they've been screened. Everybody walking into my office, staff included, will have thermometers taken on themselves and have a questionnaire and docked properly.
That's
So
a great point.
Once you get through the glass wall, you've been checked. So my administrative team behind the glass wall can do all the testing without putting a shield on. We've got a shield. I put a floor to ceiling shield of solid 1.5 inch glass.
Right.
To me, it's better than any shield. And I've got a little opening that they can put their hands in to pick up the sanitizer, pick up the gloves, and we thermometer them right through the glass. So we're protecting our staff as much as we're protecting the patients.
Yeah.
And that's an optics that I think everybody wants to see. Like Walter says, you've got to have rooms. If you have like an orthodontic office, Lisa, I mean, that's the ball game. But I mean, in terms of isolating, I just believe the patient's standard of care for them, without us doing anything, is going to be elevated to a point that we are going to have to protect ourselves. And that's why it's an exciting time. It just changes the whole thing.
Yeah.
It makes us more relevant in what's going on in this world. And I think it's a great opportunity what we're going through now. Maybe.
Okay, Rick, I see.
So if you're in a closed room and you have a high-speed fail and you need a new one that is outside of the closed room, how do you handle something like that? A lot of times we need an x-ray during a procedure. How would that be done?
Okay, I'm going to share with you. They're adamant. Once you are in that aerosol room in your PPE, you cannot leave it until you doff. Whether that's realistic or not, right? I mean, once you start practicing donning and doffing, but this is why phase 1 is just urgent care. You can't, I mean, that wouldn't allow you to do hygiene checks. That means you have to disrobe before hygiene checks. So I think that's why they're bringing dentistry back slowly, but it basically says once PP's on, you go into the aerosol generating room. The door is shut. Most doctors love this. The door is shut and no one can come in that room when that aerosol is being created. The door is opened one time for the people to come out, for the provider and the assistant once they've doffed, and for the patient to come out. And that's
that's a real challenge. So here's the thing, right? Let's talk practical. You're an endodontist, you're a general dentist doing a root canal. You got a closed room. You need to check with x-rays your lengths. You need to verify a few things. So you're in the room, you've opened the tooth, you have a rubber dam, you have high suction, all these things are going to your advantage. The room is closed. Let's say you even have that. You have to walk out of that room to take that x-ray to verify. It's not practical to walk out of that room, take everything off, take an x-ray and walk back in that room. So at that level, I would say, you know what? There's going to be some challenges in dentistry. We need to have science help us out here. And this can't be controlled with an all or none type of principle here. We understand that in a room, when you're starting creating an aerosol, that's a room where you want to try to maintain the doors closed, maintain that exposure. But in dentistry, not every procedure is able to do that. And we have to step back from those type of all or none rules and try to figure out what these exceptions are.
right.
A question, how do you leave a treatment room and go to do a hygiene check? And Rob, you were talking about this yesterday.
Not yet. That's why they're not coming. You don't yet. That's why Walter said we need, every day things change. We need the science to help us. Right now, a doctor can't take a gown they've used on an aerosol patient and go to another room to check hygiene, right? And hygiene, the only hygiene that can come back is hand scaling. And some people choose to do that, but they're not going to be doing recall exams on the fly like you're used to in this stage.
Lisa, when I'm sure hygiene will come back, why would you not be allowed, if you have proper protocols with proper PPE, have a hygienist work on? There are some bad period patients out there that haven't been cleaned in 3 months. They're going to want to come back in pretty soon.
Scale. They just can't use ultrasonics, and I can tell you,
why can't you use a Cavitron if they've got proper PPE and suction in the room, and you put an assistant in there?
Because that's not listed in phase 1 as.
That's correct.
Dental hygiene's been considered elective.
Even if it's even if it's perio proven?
It's very clear, and every college has considered the same things as elective.
Okay.
Right.
Yeah. So you
So-
get,
Florida is slightly opening now, and it's exactly for those cases, Rob, but it is very
hand skin.
emergency only hand scaling. The issue it is also some of the colleges of dental hygiene out there are not teaching hand scaling anymore.
Well, that's like us
Yeah.
doing, it's like us doing a filling without a drill.
Yeah.
That might be difficult. Like,
Yeah.
how do-
Yeah.
Yeah, but I think as far as too, a lot of hygiene's not coming back because if we can't get PPE for the dentist, we're not going to have it for hygiene. And please, as employers, do not bring the hygienist back without the equipment. I caution you.
They won't work.
Yeah.
They
I
won't.
like get it perfect before we bring them back. We're going to get it perfect.
Yes. Yeah, and some of these rules, guys, it starts with the Minister of Health in your province, then it goes up to Health Canada. These are made, and then it comes down to the college to kind of follow the rules. So the college really isn't creating the rules. They're following these mandated things that are coming down. In regard to hygiene checks in phase 2, phase 3 going forward, Lisa Philp for years has been talking about an annual, every once a year or every 18 months, a full check, a full exam check where the patient comes in a non-aerosol environment. You do the x-rays, you uptake, you do an examination, do a treatment plan, and then you don't need to see that patient till the next year and a half cycle. So now you can create a practice that is hygiene checklist style practice.
Yeah. And if they have their annual dental physical on a regular basis, then the dentist only is called when something goes wrong. The patient is, you're following them through with the treatment plan made at that time. You don't have to go get the dentist 80 times a day.
That is correct. And the cost of PPEs in terms of having to put it on, take it off to go do a hygiene check, once you run the economics of that versus having annual or every 18-month checks in a non-aerosol style practice with a client treatment planner, you are going to advance your care and you're going to be able to save yourself time. Dentist, I want to stay in the room and work with my patient. I don't want to walk 8 times out of that room and go do hygiene checks and come back. This now gives us that opportunity to really elevate our game.
Well, I also said what I said, I also believe that if you're able to have a recall doctor.
Well, we'll cross that bridge in phase 3 because we don't know what they're going to mandate with hygiene, right?
There's a question about how do you lobby the government about some of these concerns that dentists have? And I would suggest from my government background, that is what the provincial dental associations are for. And unless Walter and Rob and Lisa can state differently, but I would suggest if you have particular concerns about where this is going, then connect with your provincial
association, not the college is for the public, Rick, just to clarify. Right. The associations are for you, the professional. The college is all about covering their butts so that patients are taken care of. So if you lobby the dental associations, if we all do this together relentlessly to help us out, I don't think you have to get a 5,000 people petition, but there is a petition going around. It's on our website if you want to sign it, that basically says you're someone that advocates for an evidence-based aerosol information. And it's really about this 120 minutes. They want to know the science behind it. And there's lots of smart dentists that have found science that shows, like Walter said, aerosols don't need 2 hours to sit.
Right. And across Canada, every province does it differently. In Ontario, we have the Ontario Dental Association, we have the Royal College of Dental Surgeons. These two bodies have maybe competing forces. In some provinces, these two bodies are together. They work as one. And so the idea for us is that as a voice, we should have a stronger voice into politics so that our dental associations can take the message that we as dentists, as hygienists, as dental assistants struggle, that they take it to the ministers of health, that they take it towards Health Canada, and they can make these advancements. The difficulty is that when you have the two bodies that compete, we don't know where to turn to generally and who's going to support us in these ventures. So I think this is the time when the colleges need to kind of work together at the same time in order to advance dentistry.
Yeah, it's a nice thought. Okay, so Gav, I just noticed for time, are we at time?
We're just 2 minutes away from 2:30, which was the scheduled end date.
Okay.
Yeah.
So Lisa, can you emphasize again where the people that are tuning in and getting connected with Transitions and you for the first time, where they can go for information?
Yes. So transitions, those of you who don't know us or do know us, on our website, since this started 50 days ago when we made the announcement that I was keeping my team on payroll, we were going to be there to support our family, and also now the profession, is tgnapracticemanagement.com. And Gavin, if you could please flip to the closing slide, because I do want to put, this is something that's not on there yet, that we just got word of, which we could, next week we'll talk about the other equipment, and what I think we'll do with these questions is we'll pool the commonalities, and then maybe we can use those next week to get started, because there was a lot that didn't get answered here, but we could be here all day, right? So if you want, big part of, I think, the future of dentistry for our own safety is going to be telehealth and teledentistry. So Transitions has worked with creating a platform for our clients for sure, and our family, but also that you can use to be able to do triage, virtual dental assessments, diagnosis, and exams for your emergency care. The days of patients walking in and disrupting our days because they have a toothache or calling expecting to come in 15 minutes is going to be challenging in this model. So this is a phenomenal, with the help of Ultima, actually, and some very, very brilliant medical doctors. We've got this ready to go. I will be letting everyone know in the next week how we can get this in your practice. And there's, whether it's whatever you use, this is just us in our innovation and the commitment I made a month ago to keep innovating for the new normal. This is going to be a big part of what can happen with not having to have all the patients go through this for an emergency exam.
Great.
Okay, so do we want to close with anything?
One more question. So we mentioned that there will be a video recording of this available. Gavin, can you enlighten us as to how that will be available?
On the
Sorry, Lisa?
on the survival guide page, correct?
Yeah, correct. So there'll be a download link posted on the resource section of the survival guide page. We've made the tgnapracticemanagement.com homepage for Transitions the new COVID survival guide page during this time, so it's easy to find. The last tab on the right says resources, and it will be the latest document there.
And if you want to make sure you're on our list for COVID tips each day, please make sure you go and opt in on our website so we don't miss you. As far as wanting to get things, we're basically daily. And everything we've talked about is there in writing with more data and resources. We have wonderful examples of what our clients are doing. I want to leave you with this. In the next week, you work with your equipment, work with how you're going to get what you need to get started. And then we've got to talk about over communicating with the patients. There's a sample. Today will be, I think, tomorrow morning we'll be loading a reopening letters template for you. So when you are reopening, and how to explain the process to the patient. And then next week we'll go through the step-by-step of patient flow.
Yeah.
As far as what's going to change with that. And remember, Ontario hasn't put out its guidelines. BC's on the brink. And so what they're going to be able to say in the two biggest provinces, because BC and Ontario have the similar HR rules as well. If you want anything to do with human resources, we didn't talk as much about team today, but Chris is there as the transition specialist. She's been a godsend to our team and being able to keep up with all the different rules. She can explain to you the challenge with, you've got employment agreements and layoff terms of the provincial guidelines of 13 weeks. When an employee moves past 13 weeks, if there's not something in place, they're considered terminated. And I don't want all of you to have severance liabilities. So there's we'll probably put that on if there's interest. I have one last thing to say. If you are a dentist and you do not have access to N95 masks or KN95 masks in the next 2 weeks, could you please just leave us a note on the chat line that you are someone that is in need of PPE masks? Gowns you can sew, you can rent, you can buy. Caps, you can do whatever you like. Put it out to your team. There's lots of sewers out there. I had to put out a sewing pattern. I never thought I'd see the day from some great managers in BC that they provided. So I think just give us a note if you are on this town hall and you do need PPE masks. We'd love you to put a note and just put your name or not. If you have other ways to get them. That gives us.
I just want to make sure we're going to get this. So Gavin, there's already people responding on the chat line with their names stating what they need. So I just want to make sure that we have everything we need for the transitions team to respond accordingly.
Yes, I'll make sure that we take a manual copy now, but also the Zoom software will allow us to download a copy. And also, just to let everyone know, after this is over, I think a lot of the confirmations from Zoom has myself as a reply to address. So if you want to send me any questions by replying, I'll forward it on to the transitions team as well for easy access to us.
And I'd like to close with a genuine thank you to all of the amazing people, all of our partners. Rick, in your experience, we have the privilege of working with so many varieties of different dentists. Dr. Walter and Dr. Rob, we thank you for your openness as part of Transitions Advisory Group. We will be here for you every Tuesday until we get this right, because we have one mission. If dentistry as a major player of the gateway to overall body wellness, to be back in business. It might not be the same, but we've got to go with each 1 week, 1 day at a time, 1 week at a time. And I really hope we're not still here at day number 90. I might not be able to make it. My team might need to take 2 months off just to sleep. So thank you again to everyone. We're all in this together. Dentists aren't an island. We'll band together, and I hope this has been beneficial. And if it has, let us know. And that which is rewarded is repeated. So we'll keep going if you want this.
Thank you. Thank you, Lisa. Thank you, everyone, for joining us. Rick, I don't know if you have any last words, but I just want to thank everyone for coming on, and we look forward to the follow-up, and we look forward to next week.
Great. Look forward to it too.
Okay. Bye, everyone. Thanks for joining us.
Thank you.
Make it a good COVID day.
Hi, Lisa. How are you?
Hi, honey.
So, no, I thought that went real well. I thought that was great.
Well, it's the start, right? It's opening it up for discussion. And I think, you know what it is? Is everyone still online, Gav?
Yeah, the participants are starting to come off right now. I'm going to end it now. I was just making sure I got all their comments noted down here. Make sure they're all downloaded. But
At least I can help you next week if you want. You let me know.
Yeah.
I'm good.
Well, I think what would be probably good to do is a debrief on what questions didn't get answered.
I'm following them now. I'm looking at them.
Okay. Gav, you store those, right?
yeah, but just in case Zoom doesn't do it, I'm taking a manual backup right now before I close the meeting.
You're the best. Thank you, Gavin. I couldn't do this without you.
Lisa, they want me to give out where I got the jades from, so I'm going to give you the who do I give the email for the Surgically Clean Air Company, because I see the questions here.
Okay, so
do I just type the answer in? If I type the answer in here, what's going to happen to the answer? Does it get wiped out?
If you type the answer in there, it's going to post the answer to the person who asked it. They can only see it via text, via on the screen, but they might be gone now.
right. So you know what, Rob? We'll
There's
we
still a
will
lot of
follow through after this.
Sorry, there's still a lot of participants on the line.
Yeah, so I'm going to just post the email for the guy. I think I got it here somewhere.
Yeah.
Just give me 1 second. I'll do it. I got to find it.
So Gavin, let's pool what we couldn't get to.
Okay.
Okay, and then when you do your follow through for this one, and then we'll do a link to the master checklist.
Right.
and then register for the next one, right?
For sure. Okay. I think I got everything downloaded. I'll close this now and we can follow up with each other on a separate call.
Sure.
Put this in.
Bye, Rob. Miss you.
Hey, honey, I'll speak to you later, huh?
Okay, I will. I'll call you later. Bye.
Yeah. Anytime, huh?